of halos also. So, and the distance contrast will be little compromised. That's in my practice I see. And this is VVT, the VVT lens of Alcon. You can here also you can see this is the wave technology they have used, and this wavefront technology also same pattern is there, and you can see this extra ring is giving more intermediate than the monofocal enhanced monofocal lens. And when I compare all the lenses, you know the photon entering into the eye. Any eye, the amount of photon entering is the same. There is a constant. But what is happening is you look at the Alcon plane, and this is the Technis one, monofocal. This area is dropping here. But enhanced monofocal, this is the enhanced monofocal. So this area is being transferred to here. So that area is reduced and that is added here. In VVT, what happens? The same amount of photon is entering, so they have to adjust somewhere. So what they do is they adjust this area and keep it there. So it's according to the patient, which area you want. You want, mostly you are working on intermediate area and distance is not that problem for you, then you go for EDOF. Otherwise, only a little bit of, like when you drive, you want to see the dashboard and you want to cut the vegetable, it's okay for them, then you can go for a enhanced monofocal. So that is the basic difference between the two. Now we come to the patient satisfaction point. And then I just show you one video, like this is one EDOF lens, and this is actually, this EDOF lens is a little, this is Appasami's lens in focus, supra phobe in focus. You can see the central ring there, and this is another, this is the symphony. Multiple rings are there. Now, regarding the patient selection, you look at this, many studies, I have seen many studies, you look at what they say is, here they have compared with monofocal, enhanced monofocal and EDOF lenses, the intermediate vision similar to that of EDOF IOL, that's what they say. Even in the enhanced monofocal, they also give almost a similar intermediate distance with the EDOF. So in that case, the problem is in EDOF, you will have a contrast loss, but in monofocal enhanced, there is no contrast loss. Again, this is another study which shows that, interestingly, there is no significant difference were reported for the visual acuity at the intermediate vision. See, again, it says there is no much difference in intermediate vision, and both these lenses are not giving the near vision. Now we will see which one to choose. It's purely the patient and doctor's choice, but you look at this enhanced monofocal, it gives an excellent good vision. EDOF gives fairly good distance vision. I'm not saying it don't give, but the contrast will be less. And again, intermediate, both are giving good intermediate, maybe a little advantage there for EDOF. But the glare and halos is almost nil in enhanced monofocal. The other will have glares and halos. Again, regarding the cost factor, you get it enhanced monofocal for 10,000. The other one is almost 2 to 3 times more. And again, it is pupil dependent. EDOF is pupil dependent because there's a rings are there. It is pupil dependent. And there is no contrast loss in enhanced monofocal. And both the lenses you put, you have to give a spectacle for near vision. So it purely depends upon what patient's choice and what their financial status and the doctor's choice. Thank you.
That was a very wonderful presentation by Anish, comparing the two kind of lenses in the enhanced focus. Next, we have the premium IOLs in today's practice by Dr. Krishna Prasad Kutlu. Sir.
Thank you so much, Kerala Ophthalmological Society, for this opportunity. So, I'll be talking about premium IOLs, and I don't have any financial disclosure for this particular talk. So what is premium? Generally, we consider multifocals, trifocals, EDOF are considered to be a premium. Toric multifocals also part of premium. Toric monofocals also part of premium. Even nowadays, even most of us consider aspheric monofocal lenses also considered to be premium lenses. Coming to the patient selection, for me there is no age criteria. Youngest to the oldest, he can opt for premium. But always I avoid multifocal in patients with the congenital cataract. If I do a cataract in one eye in especially young patient, I avoid multifocals. Coming to the occupation, premium monofocals and torics are for every profession. I always avoid multifocals, especially in drivers and profession with fine arts, pilots, surgeons, even armed forces. Again, depending upon the surgeon choice. But these multifocal or trifocal best tolerated by retirees, housewives, computer professionals, writers. As Dr. Anish said that EDOF is the best for drivers and software persons. So always you should look at the patient attitude. Always patient is think that I don't mind wearing glass for reading. I always avoid them. Some of the patient ask me, will you guarantee spectacle independence? I always tread carefully. Some of the patient like complained of glare, I think you have to counsel them well. Then the worst scenario, what I always feel that I paid all this money and I have to wear glasses, they may ask. So coming to the clinical judgment, it's very important to ask for a amblyopia history. You need to look for pinhole vision, color vision, and comorbidity like age-related macular degeneration, glaucoma. This is very, very important. So often where we missed, always all my premium patient, I do the proper dry eye workup. You treat the dry eye, then you go ahead with the treatment. Always I do corneal topography just to rule out any irregular cornea. I do OCT to rule out any epiretinal membrane or age-related macular degeneration. I got a scan where I can find out whether the patient is having a loose zonules and always make sure that patient doesn't have glaucoma. So coming to the post-keratorefractive surgery, will you implant a multifocal? Again, depending upon their regular ocular surface. Then what is the near ad for multifocal? Can we advise trifocal to all the patient instead of multifocals? Leaving aside the financial consideration. Then next question arises, need to operate both the eyes in quick succession or not? This is very important. So coming to the preoperative counseling is, as Dr. Chandrakant said, is very, very important. Always you have to tell the patient, sometimes they may require to wear the glass for a very fine print, and every patient I tell them that you have to read in extra light condition. And always you should show them the advantage of spectacle free vision. And also you should tell them, always you should look at the other eye condition. Always you better to avoid a hypercritical and demanding patients, and keep always option of monofocal open in technical difficulties during the surgery. This is very important. And also tell the disadvantage of intraocular lens also. So coming to the point about biometry is very valuable too. Although premium IOLs can be practiced with ultrasound biometry, but sometimes every surgeon will have a fear of surprises. Because sometimes what happens, these newer formulas may variable with the difficult to obtain from A-scan. Always I opt for this kind of biometry. Because the advantage with this biometry, you can have a full length tomography that shows the anatomical details in the longitudinal section of the eye. We can have an accurate AC depth, and even it can even find out about the suspected any tilt of the crystalline lens. Coming to the post-keratorefractive surgery, probably I don't have any financial interest with the IOLmaster 700. Probably TK is probably priceless future. You will have this Barrett True K formula that gives the perfect reading. That is very, very important. So coming to when you're practicing with these premium IOLs, with these visual angles is important. I personally feel yes, because angle kappa is a angle between the visual axis and the pupillar axis. The most important one in cataract surgery is angle alpha.